let's welcome Jonathan Tritter. So this is a part of the University of Newcastle and Aston International Research collaboration that we've been doing for a couple of years now. Unfortunately, due to COVID, we weren't able to host Jonathan and Gary as visitors to the University of Newcastle. So the next best thing is to have a virtual conference. So Jonathan Tritter is a professor of sociology and policy at Aston University, and we'll be talking about bringing the state back in, reconsidering the response to global and planetary health. And then Daniel will be discussing your presentation, and Daniel's a professor of Management and Organisational Studies at the Uni of Newcastle.
Thank you very much for this, and sorry for the technical issues. It's a great opportunity for me to share some of the thinking I've been doing. Indeed, this is a talk I gave first in Örebro University in Sweden almost a year ago, though I think some of the underlying rationale for my thinking then is even stronger now in the light of COVID. So what I'm going to talk about really is, in a sense, reflect on the ways in which public health as a discipline has changed, and indeed the way it has moved to a much broader framing, the emergence of global health or planetary health as the primary name for public health, and the implications this has for thinking about health risks. Clearly, it's useful because health risks don't recognize nation-state boundaries. COVID is an excellent example, but there are lots of other ones, like pollution, for instance. And in some sense, a global health or a planetary health framework creates greater opportunities for action at a global level. It creates opportunities for global actors, supranational actors, the WHO, the UN, and NGOs, all to have a voice to shape and frame the perception of risk and potential responses to it. But I want to argue that there are some negative consequences for it. And in some sense, we could frame public health in a different way that might be more fruitful, not only for the actions needed to mitigate health risks, but also for ways in which we can promote research and ways in which we can support the development of a more informed public health workforce. So as I said, I presented this in Örebro a year ago, but I think things have developed to strengthen my argument. I'd be really interested in thinking about ways we might take this argument forward, or whether I'm just talking nonsense. So in my world of health policy and international and comparative health policy, there's lots and lots of comparisons at an international level, whether it's the UN or the Commonwealth Fund or Bloomberg. All these frame different ways of comparing international health care. But most of the comparisons rely on perceptions of health services, how healthcare is utilized, who utilizes it, and different kinds of outcome measures like death or illness. There's much less comparison about well-being, how healthy, or how populations live with different forms of disability. There's much less comparison premised on the ways in which health risks are responded to. In that sense, public health, as in most healthcare systems, has a much slower profile. It plays a much smaller part in the ways in which we compare healthcare and health and well-being internationally. Though I think one of the things that COVID may do is create much more primacy for public health. It certainly raised its profile, or at least the profile of certain epidemiologists and certain members of the public health community. Public health has gone through this evolution. Health and well-being are different from illness, and public health continues to be about responding to health risk, prevention rather than sickness. In the UK, the National Health Service is often referred to as a sickness service rather than a health service. You only come into contact with health systems typically when you're ill, though of course pregnancy is a different kind of engagement. But public health is premised on well-being, not health care. It's about ways in which we can prevent disease, prolong life, and promote health. It's also about the coordination, and indeed lots of aspects of public health rely on aspects which are outside the broad remit of health systems. water purity, issues of transport, pollution. All of these are things that are outside typical measures of health systems and health care, but are intimately related to how public health articulates risk and prevention. And clearly, we say that threats to health don't stop at national borders. Whether it's air pollution or acid rain floating across a border from a power plant in Eastern Europe, or COVID floating across international airlines from Wuhan. And that threat of global pandemics is real. It's important that we recognize that a global framing helps us prepare. The World Bank, a little while ago now, estimated that a severe pandemic would cost 0.7 of the worldwide GDP. I think they may have to recalculate that figure. And we can think about the 11,000 people who died in the Ebola outbreak. How is that dwarfed by what's happened with COVID? That sense of being prepared or being unprepared for a pandemic was leading up to where we are now. And it's clear that we weren't prepared. Though, to some sense, Southeast Asian countries, because of SARS, were in a much better position to manage their own national risks. Global public health is about health problems, issues, and concerns that transcend national boundaries. They're influenced by circumstances or experiences in other countries and are addressed best by cooperative actions and solutions. They rely on coordination between nation states, international and national actors. Health issues circumvent, undermine, or don't recognize territorial boundaries. Individual countries can't address global risks. We need to think about ways in which people across the planet are at risk and ways in which this can't be engaged with solely at a nation-state level. Obesity is an obesity epidemic, a crisis. The media is full of ways in which we should engage with this potential pandemic. Tobacco, too, is seen as a global threat. $2 trillion a year are spent engaging with tobacco just in the US alone. A person dies every 4.5 seconds from tobacco-related disease. So global health frames health risk at a global level. It challenges nation states to coordinate, act, and to engage with and mitigate those risks. But planetary health goes even further. It says that we need to take into account the planet itself, the ways in which the ecosystem and the environment are essential to human civilization, and their own fragility is part of what we need to mitigate in framing a planetary health approach. The Rockefeller Foundation Lancet Commission on Planetary Health said that planetary health is the health of human civilization and the state of the natural systems, achievement of the highest attainable standards of health and well-being and equity worldwide through disattention to human systems, political, economic, and social, that shape the future of humanity. And the Earth's natural systems define safe environment limits within humanity can flourish. So in that sense, it's not enough simply, we can only maximize public health and well-being if we take into account the environmental consequences of human activity. And planetary health started to really have some salience in being moved forward. It certainly is reinforced by the increasing attention to climate change and a need to respond to that. But what about public health? The birth of the discipline is often seen as Dr. John Snow and the Broad Street Pump in London in 1854, where he noticed a cluster of cholera cases around the pump, and he thought there needed to be a public health intervention, and that was a lock put on the pump, and the cholera cases declined. So it's a classic case where observational and spatial epidemiology led to identification of a problem, identification of a solution, and an intervention, an action to mitigate the risks associated with those. In some sense, that classic approach to epidemiology is still where we sit. But in this example, we're talking about a local problem and a local solution, one that takes into account the particular circumstances of where John Snow was, Broad Street in London. Public health, too, draws on a connection to tropical medicine and colonialism. The foundation of the WHO in 1948, the Alma Ata Declaration in 76, and the current Millennium Development Goals all are connected to that history, the ways in which colonialism and tropical medicine have shaped perceptions of health risk, where poverty is seen as a central issue, and the difference between developed and developing, between the rich and the poor nations, is at the heart of what we need to think about in order to achieve those MDGs, the Millennium Development Goals, and then the Sustainable Development Goals that we're working on now. So thinking about these sources, the emergence of public health, its rearticulation as global health, and the push towards planetary health, where has this got us in terms of the recognition of health risk, the identification of strategies to address or mitigate those risks, and action to actually do that? What are the successes of global health? Well, what about tobacco, a global response to tobacco? The WHO Framework Convention on Tobacco Control, the FCTC, entered force in 2005, and it requires countries to translate the general provision into national laws and regulations. It'll have 3 years from the day it comes to force, and it requires strong health warnings, limitations on tobacco advertising, promotionship, and sponsorship bans. It was ratified by 40 countries in 2004, and currently there are 168 signatories. But how did it work? This is an example of the identification of a global health risk, the catalysis of concerted action, global coordination of nation states to address this risk, trying to get NGOs and civil society organizations on board. And indeed, the literature suggests that it was the civil society organizations that did the most to create this coordinated response, far more than the WHO and the UN managed. Indeed, there are 15 members of the UN who never ratified the treaty, including the United States. So, despite this coordinated effect, the identification and diagnosis of a risk, the identification of potential actions to mitigate that risk, compliance, action has been limited. It's often misreported, it's misinterpreted, it's not coordinated, and it's hit and miss. The health initiative was led by the supranational health bodies, and its success is a treaty, a document ratified by 168 countries. But it also identifies and has been responded to by global corporations, big tobacco. It's not clear that it's made a difference in practice on the ground, and the responses have been very varied. It may be that EU oversight has been more successful, but again, EU is also a supranational actor and also is constrained by the interests of big tobacco. What about the other example I presented initially, the global obesity epidemic? What about a public health response? The risk was identified, a potential response, a sugar tax, a soda tax was suggested, but there's little global scope for global coordination around a tax. Taxes are the responsibility of nation states or regional authorities or municipalities. And there is lots of current debate. The WHO Independent High-Level Commission on NCDs recommended an international code of conduct. It presented a model of what a soda tax might be. There were opportunities from international NGOs to propose particular ways forward, ideas and models to argue for and implement particular types of taxation. And there is example of nation-state level action in France and Mexico and the UK and Finland. And there's even more examples of action at regional and municipal level. So this is an example of the Berkeley referendum in 2014, trying to impose 1 cent per US fluid ounce on high-calorie sugary drinks and the sweeteners, whatever those sweeteners are. So that's the wording of that proposition. And the soda tax in the US were always framed in that sense, 1 to 2 cents per fluid ounces. And we had examples of success in different municipalities in California, in Colorado, in Pennsylvania, and New York. So all of these are examples not of concerted state action, not even of regional authority action, but here these are municipalities acting. It did engender significant debate in the media, debate in the public, lots of campaigns. And again, in some sense, this is because there was a significant vested interest, big soda, the complement to big tobacco. As Vicki Alexander, the co-chair of Berkeley Health Child Coalition, put it, the reason for such attacks is clear. 40% of Berkeley Unified ninth graders are overweight. An African-American resident is 4 times more likely than a white resident to have diabetes. It's unconscionable to stand by and do nothing. Be for Berkeley and against big soda. The health of our children and our families is at stake. And this is countered by Roger Salazar, the spokesman for Californians for Food and Beverage Choice, an interesting title of a political action committee. Our view basically is that beverage taxes aren't the solution for changing behaviors or teaching people about healthy lifestyles. A regressive tax on common grocery items like sugar-sweetened beverages in Berkeley won't make people any healthier, but it does have an impact on businesses and consumers who are already struggling to make ends meet. We shouldn't have more taxes. And indeed, big soda spent a lot of money. The American Beverage Association and Coca-Cola and PepsiCo spent $67 million in that 7-year period on local and state initiatives, arguing against soda tax, lobbying against that. And that was in addition to the $15 million spent at federal level, at nation state level. Indeed, in Berkeley, they spent $2.5 million just on the campaign to vote no, but they were active in other Californian municipalities. Coca-Cola Europe, too, articulated the potential risks associated with this type of public health measure, the ways in which they identify the opportunities for fighting back and preparing and preventing, the identification of those who are allies or antagonists, and the likelihood and the impact of different kinds of measures that might be put into place. Richmond, California, here this is Councilman Jeff Ritterman, who was a retired doctor, and he spent 6 months walking around town pulling a wagon filled with a container full of sugar, the sugar equivalent to how much each child consumed in a year. That kind of grassroots action made a huge impact and changed the ways in which the petitions, the referenda, were dealt with in California. And in the end, Berkeley's residents voted to promote the health of their neighbors over the profits of big soda. But the global call to action hasn't really gone global. In some sense, this is limited by the governance structures, the ways in which, at least for instance in the United States, it would be very difficult for the federal government to pass a national sugar tax. That is, the governance structures that are essential to actually creating the public health intervention are constrained, multi-level, and uncoordinated. And each of those different levels creates a new opportunity for both resistance and lobbying from multinational corporations, from big soda or big tobacco. And while there is examples, as I've suggested, where it has made a difference, where action has occurred on the ground in practice, this has been sporadic and certainly not global and certainly not coordinated. So while global health has been effective in some sense in identifying a risk, a global health risk, and proposing potential actions to mitigate that risk, it hasn't been able to coordinate action, and it hasn't been able to act. The supranational bodies are not actors, they're influencers. They have limited power and limited resources to take forward and mitigate the risks that they've identified. They cannot regulate, they cannot pass tax requirements. They have to act on cooperation. They have to assume collectivism. And yet decisions that are made are a consequence of international relations and the hierarchy and power differentials that are embedded in those structures. Those policy responses are delayed and limited and constrained by the countries with power. The very fact that the US didn't sign up to the FCTC is just an example of that. And unless the powerful play ball, there's even less expectation that the less powerful countries will also. The US withdrawal from the WHO under the Trump administration is the latest example of ways in which international relations mitigate the opportunity for global health to be effective. And it's not just in health. The US blocked the appointments of judges in the WTO, limiting the scope for the regulation of international trade. So if the implementation, the response to the global health challenges that are identified is based on governance structures within states and under states, the sub-levels within them, whilst unified governments, the United Kingdom, for instance, can pass legislation, mostly we have examples of federal states where regional authorities or municipalities have power to make policy and, most importantly, to implement them. And that creates an even greater challenge for action. It's also a challenge for research. As we've seen with the examples of COVID, looking at national statistics on morbidity and mortality hides as much as it reveals, because it's really at the local level where we see pockets of illness and pockets of death that tells us more about the implications of particular populations or particular responses on the ground. Looking at it at a national level doesn't really help us. And that creates a challenge for learning. Unless we understand what's happening in those examples where things have gone well locally, we can't try to identify ways we could follow models for positive action. And it's a challenge for training. In the end, the public health workforce have to work on the ground. They have to take into account the local context of where they're working and what they're doing. And we need them to understand that diversity and heterogeneity and the importance of responding to the local resources and the local opportunities. So when I gave this talk a year ago, no one knew about COVID. Well, I suppose some people knew about COVID, but no one had told anybody else yet. Indeed, it wasn't until the end of December that that first cluster of cases in Wuhan was first reported, or the 5th of January when WHO issued the disease outbreak report. But within a week, the WHO had suggested comprehensive guidance. They had identified a potential global risk. They had proposed ways of mitigating that risk, ways that nation states could manage the outbreak. But they couldn't act. They couldn't tell the nation states to do. They couldn't regulate. So what we had is lots of variation. China quarantined Wuhan. And even after the WHO declared a global health emergency, a public health emergency of international concern, it took time before anything else happened. Even after the US declared a public health emergency, it didn't necessarily lead directly to action because it, under its federal structure, can't impose regulatory authorities over and above what the states do. So what we see, and these are just a whole varied selection, what we see is uncoordinated, diverse actions. And it may be that most of them responded to some of the models that the WHO set out, but they pick and choose different types of response, and they're implemented in different ways for different periods of time. And that means we have a lack of coordination. And it also makes it very hard to compare and contrast different nation-state responses, because the nation-state response itself is not the thing that matters, but what happens at local level. So clearly we have this example with COVID, where the WHO did recognize a risk and did provide advice on how to respond. And we have lots of examples of the differential and heterogeneous response at nation-state level. Whether that was restrictions on travel and trade, or internal restrictions on movement, or approaches to testing and tracing, or not. That means that the international comparisons highlight the variations. but they don't highlight enough of the variations. We also have this case where 80% of the Pfizer vaccine and 53% of the doses of all the promising vaccines have been purchased by the richest countries, with the 14% of the world population. What about the other 86%? If this is a global health risk, then this lack of coordinated action is only going to prolong that risk and increase the negative consequences. Even Canada has bought enough vaccine to inoculate its population 5 times. Does it really need that? What about the South? What about poor countries? International relations, the relative power between nation states, continues to explain far more about the responses to the pandemic than the global health framework that was seen to identify and propose mitigating strategies. A global and planetary response hasn't led, a global and planetary approach hasn't led to a global response or mitigated the impact. It's done so in pockets, in uncoordinated and heterogeneous ways. I think we need to bring the state back in. I think global and planetary health are important, but what they do is highlight issues. They help us consider the global interests that can provide resistance to potential responses to global health challenges. They identify arguments, they propose response, they present models that help nation states think about how they might respond. But what they don't do is act, or indeed coordinate the actions that need to take place. They can't understand enough about national, local, or regional variations that change the ways in which those responses are articulated or need to be implemented. Global health relies on that devolved administration within nation states and nation states itself to actually act. I think what we need is to provide an alternative framework, one that recognizes the primacy of the nation state as the unit of analysis, where we think about how we can promote learning, research between jurisdictions within and between nation states, where cross-national research takes into account those variations in international governance structures that change the ways in which mitigation responses are articulated and implemented. But the question is, where do we go from here? And I'm hoping you're going to help me with that. Thank you very much.
Thanks for that very interesting talk, Jonathan. I'll hand it over to Daniel. Daniel, over to you.
Thank you, and again, thank you, Jonathan. Really interesting and well-delivered talk. As it was nice to listen to you. I really enjoyed just listening to you. Your voice was very well articulated. Your arguments well laid out, and you held me for these minutes. So, thank you. I really enjoyed that. And I also think there's a lot of things in your talk that was thought-provoking, and I guess I agree with most of your major point. I do think the idea of a global health is a bit overplayed, and it seems to me that those state boundaries today are often used for the opposite of global health. It's sort of the state boundaries are used for international or country competition, and that we close the borders, or we call it the China virus, to distinct this one state from another. So I think borders are often used and implemented in these instances to strengthen the state, or that is your own state in which you are positioned. And I also think you pointed out rightly that this comparison between different states are problematic on a global level, because they are so varied, not only in the jurisdiction but also in how the legislation surrounding them. So I think it is problematic. So I agree with a lot of what you said. So I thought maybe I should point out things I don't agree with to create some notion of discussion here. So I don't really disagree with much you say, but I thought, why not provide a little bit of discussion here. And since I just tried to create a couple of notes while I was listening, it might not be in the right logical order, but we see how it goes. So the first thing I found slightly problematic is that you suggest that a lot of the public health has been around sickness and not about well-being or health. And I would dispute this. And I think since the 1990s, we have seen a shift with a lot of neoliberal policies and individualization and individual responsibility. We have seen a turn to health and well-being almost onto a sick level, in the sense of detrimental to mental health, that we have to perform. It's our responsibility to not be sick. We have the activation policies in most of Europe now, which basically suggests it's up to you to make sure that you are healthy and fit. So I think there is this focus on well-being we're seeing, and I think it has increased. Not necessarily given the results, perhaps, because the individual is not given the capacity or agency for the activation that is demanded of them. So I think there's a contradiction there. On one hand, we tell the people it's your individual responsibility to stay fit and healthy. It's your responsibility to not be ill, but we don't perhaps give you enough tool agencies to deal with this or support. The other sort of things I want to raise that I think needs some debate perhaps or clarification is that the notion of health, I think, has become a metaphor that is somewhat diluted. So almost like a war on, a war on health, or war on drugs, or war on wars, or whatever. Health is the same thing. So when we talk about the health of the planet or health of these things, it becomes quite a diluted concept if we're not clear what we mean. So while obviously concerned, and my research is mostly around climate change, and I probably myself I used the concept health of the planet in some writing, but still it's problematic, these kind of big statements of around health and making that analogy on a planetary scale. And partly because what you have pointed out so well is that these burdens are not equally shared. There is no global health problem in that sense, because in certain places there is no health problem compared to others. The distribution of ills are so unequal that talking about the global health problems is almost laughable. And I think this is the strength of what you're saying, is your return to local space and place, I think, is something I think is starting to shift in many disciplines. So I think perhaps the health and this kind of global discussion have had the same type of temporal focus on progress and on future, that we are perhaps at times forgetting that all these progress and temporal focus has denied some local or space or place-based emphasis that is perhaps more needed than this idea of what we have a shared future. And if anything of these kind of planetary, and I refer to climate change, has shown us that there is no shared future. The future will look very, very different for different people. And we see perhaps that in terms of who is on the streets. There are those on the street, or those without any future. So the idea of progress and temporality, I think, has been overplayed in a lot of these. And at return to space and place, which I perhaps read a little bit in the end of your talk, I think is timely, because it is so difficult to compare on a global or state-based level, that we perhaps need to return to the local. And how can we do that? Perhaps there's the point of learning horizontally rather than vertically. I think a lot of at least within my discipline, a lot of learning is abstracted. So we want to learn something and then we want to distill it upwards. And we want to create these explanatory ideas that we then translate down again to another place. But I think there's something like NGOs now done well is this horizontal learning. Like we learn from other regions doing things. We don't need a center and go back down again. So we might not need a global state in that sense. We might just need coordinated global activities that learns horizontally rather than vertically. And I think academia can play a role there in perhaps stopping our over-theorizing where we want to lift it up rather than move it across. And these spatial dimensions, of course, are a bit problematic, but I hope you understand what I'm aiming towards. And in my little discussion here, I want to add perhaps the only critique that I can have towards your talk so far is that still seem to me that you haven't theorized the state. You seem to hold on to an essential notion of state as a clear body, and perhaps in a paper the state itself needs to be problematized somewhere to strengthen your argument. But that's only sort of academic critique. The other one is just more stuff, if that makes sense.
No, thank you for that. That's really helpful. And I think you're entirely right about that critique of the state. I'm using it as a very generic notion, and that I'm also pointing out that there are different forms of state and that constrains opportunities for action. I think that's right. I take your point too about the growth of consumerism in healthcare and ways in which this creates, it shifts responsibility for health and well-being to the individual from the state or state actors. And you know, this is not new. In some sense, you could argue that Parsons' sick role is an exemplar of this kind of articulation. But I still think that what we're seeing is that push for health promotion or health prevention or illness prevention on the basis of neoliberal ideologies rather than in terms of the population's health and well-being. It's much more likely to be for working or the workers that we're seeking to promote prevention and exercise rather than for the population as a whole. So it reinforces the inverse care law. It makes it harder rather than easier for us to promote public health and well-being. And I guess I was trying to make the point that the bread and butter aspects of what public health is have low relative status, and they're not acknowledged or not acknowledged very much in international health system comparisons. And really what that does is miss an opportunity to understand underlying health status and then recognize what health systems do in relation to that health status. And that's a much better way of understanding, you know, the relative cost or benefit of a particular kind of health system rather than in an absolute way. I think too, this notion of health of the planet, the personification of the world, rather than understanding the ways in which there's an interaction or an interdependence between the environment and the public's health and well-being, can get lost in that translation. And I guess I was trying to argue once again that public health is one of those disciplines that requires lots of things beyond classic definitions of what is health or what provides health. Just as clean water is partly about regulation and environmental protection, it is also about the nature of the environment and the status of the environment. So I agree with that. And this notion of shared future and inequality, which is not limited to understanding nation-state populations, but actually is about national and international comparisons, the ways in which the poor countries are going to be even more disadvantaged by ecological change and more disadvantaged by responses to COVID and other kinds of large-scale global health risks is problematic too. And we should expect those global actors like the UN and WHO to lead ways to mitigate this. But national interest appears to be too strong. And I would argue global economic interests, so the interests of big corporations, mitigates or even surpasses the interests of individual nation states to address or undermine opportunities for coordinated responses. But thank you very much for those comments, that they are helpful.
I'll open it up to the floor to see if there are any questions from those of us that are listening.
You're making an assumption there, Adrian.
We can't see you. I have a question. So,
oh, sorry.
Marcello, my question, Jonathan, is what do you see as some of, given, using the examples you've given, including COVID and some of the planetary issues and the perverse incentive structure that many of us operate in, whether it's institutional, whether it's large corporations or as individuals, what do you see as some of the first steps to get the state to have this power, first of all, and then secondly, to start to coordinate across these states?
I mean, I think there are two different ways of thinking about it, and in part, I think this is what Daniel was suggesting, that perhaps what we shouldn't do is expect nation-state action. Maybe what we should do is think about significant municipalities or regional actors and try to bring them together to try and share good practice, to think about different ways of doing and to address and mitigate some of the problems that are occurring. I do think that more information, the fact if more people realized that Canada had bought 5 times as many vaccines as it needed, that public shaming might lead to some action. We might get Canada to donate some of its vaccines to poor countries. So I do think, you know, the tonic of information, the clarity of truth will lead to shaming, even at a global level. I think real politics is problematic. I think that, and we've seen this in the response to COVID, what is more important, national economies or the population's health within a nation state? And depending on where politicians sit on the political spectrum, the relative primacy of the economy over health, or the economy over, the corporate economy over the health of those who are deprived populations, is very different. And all I think we can do as academics, as analysts, is to point out the consequences of the actions that are being taken. We are not in the position to act. We, like those global actors, can only identify risk, propose potential solutions, and support that with different forms of communication and networking. So I do think we as academics are in a relative weak position, and I don't think there's an easy solution at all.
Thanks, Jonathan. Marcello, did you have a question?
Yeah, sorry to jump in like this. I wanted to write, but there was no time, so I will just ask the question directly. So I agree. Thanks for the presentation, first of all. And I would like just to ask you how, so I agree with the role of supranational organizations to lead the response and to give possibility to poorest countries to have the same chances or opportunities of wealthiest country to have access to vaccines, in this case of COVID-19, but in general to have the same opportunities to develop health and well-being. However, how would you overcome the conflict between centralized institutions such as UN, WHO, and then the regional or local approach that you are suggesting as a way to go beyond the limitation that we have seen so far in the response to public health and like pandemic, epidemic, and natural events, let's say?
Yeah, I mean, thank you for your question, Marcello. I think you're, in a sense, emphasizing some of the points that Adrian was making, that this disjuncture between nation states as actors, however simplified I've made them as actors, and the need for action on the ground is problematic. And I think we see this in places like the UK, where what we've seen is what happens in Westminster in London is not the same as what happens in Wales or in or in Scotland, or in Northern Ireland. So even within nation states, we've got disagreement by the significant regional actors. And all we can do is point out the consequences, to highlight those differences. In some sense, my call is to research which takes into account those subnational actors. And in some sense, maybe the outcome of that is some of those subnational actors saying, hey, why don't I go see what's happening in Cardiff? That will help me understand what I could do differently in Edinburgh. Maybe it can promote opportunities for bilateral, trilateral action underneath the nation state. But we can't rely on the nation state to act in a way that, in a sense, is even in the interests of all of its population, let alone in the interests of other nation states. I think that's the reality. Rich countries are rich for a reason, and poor countries don't get much help. And again, using the UK as an example, the current decision to cut the commitment in terms of GDP percentage to the aid budget is just another example of the unwillingness of some of the rich countries to move. And the US provides an example of the vagaries associated with elections. The distinction between the Trump administration and the Obama administration is significant. It's not perhaps as great as we'd like it to be, but it's still significant. It will be interesting to see what happens with the elastic coming back into sort of the mainstream. But sitting in Europe, we think about these things very different. Sitting in Europe, the Democratic Party sits somewhere towards the center right and nowhere near the left, and its orientation towards domestic issues. I mean, you never win an American election based on foreign policy. If 97% of the US population don't have passports, the last thing they care about is what's happening in poor places. I don't know if that's answered your question. It's just given me an opportunity to summarize.
Yeah, thank you. Thank you for the answer.
Is there anyone else? No? Okay, I think I've given everyone long enough to ask a question if they were going to. I wanted to really thank Jonathan again for his presentation. It really was interesting. It made us think about some of the things in life that perhaps we should pay more attention to in these rich countries that we live in. And also for taking the time out. It's early morning over in Europe, so we really appreciate the time taken out to present in your morning and our evening. So I just wanted to thank Jonathan again.
Oh, thank you very much. It was really helpful to have those opportunities for comments, and I need to think about how to articulate this in a more formal framework, and maybe we can come back together and think about how we could work on these kinds of issues. So thank you. And thank you very much, Daniel, for your points.
The best wishes. If I don't see any of you, I wish you a Merry Christmas and a Happy New Year, and hopefully we can put COVID behind us.
Yes,
in the future.
That's what I'm hoping for in my stocking.
Yeah. All right. See you, everyone.
Bye.